comes first. With airway we also secure cervical spine, and after that there is breathing, B for breathing. In breathing we look for chest expansion and we auscultate chest. If there is any need of chest intubation, we will do at that point. It is the second point. And the third point is circulation, in which we look for blood pressure, pulse, and secure any visible extravasation of blood by that time. And after that there is deformity. It is for any fracture or organ injury, and it is the fourth part where we look for any organ injury, just like head injury. But before all these, there is vital these are the vital things that are airway, breathing, and circulation. So whenever we approach a trauma patient with head injury, we must secure these 3 points before that. And after that there is exposure, and E is for exposure, in which we protect the patient from environmental hazards. As per our ATLS protocol, today our topic is assessment, head injury assessment in a trauma patient, and it is the fourth part. And in this fourth part we go through all these basic things in emergency. First of all, the Glasgow Coma Scale, which we use very frequently, and it is very easy to use. If we know the basic things about it, every guy can use it. It is not the most reliable score, but it is most reproducible score, and everyone can do it. After that, pupillary responses and any limb, any extremity weaknesses. After that we go for scalp laceration, bruising, CSF leak, herniation of brain matter. And after that, these all things we look for evidence of any skull fracture. There are subconjunctival hemorrhages which we look in the conjunctiva of the patient. Bleeding from external auditory meatus, this is also a sign of skull base fracture. CSF rhinorrhea, otorrhea, Bettel sign, and bilateral periorbital edemas. Cranial nerve and artery injuries. During head injury there are also chances of arterial dissections, and the most vulnerable artery for dissection is the vertebral artery. Here we can see a picture in which we can see that a lady is suffering trauma of anterior cranial fossa, and there is a raccoon eye, and you can see there is a discoloration around the eye, more over the right side than the left, and it is sign of anterior cranial fossa trauma. After that there is Bettel sign, in which we are looking that there is some imprint mark at mastoid region, and it is the sign of trauma to middle cranial fossa. This is Glasgow Coma Scale. It is very easily reproducible and everyone can do it almost. First of all, the component we look on, the first thing is that eye opening. When we approach the patient, usually the patient opens his eye spontaneously. If he is not opening eye spontaneously, he does it for speech. If we are asking him to open his eye and he is unable to open his eye, after that we go for a pain stimuli. The most important thing here to remember is not to give pain stimuli if patient is initially having not responding, or he is closing his eye, because sometimes patient is conscious and you pinch or give some pain stimuli, patient slaps from front. It happens usually. You must be careful. Don't give pain stimuli initially. First tap the patient. If he is sleeping, he will wake up. Don't give a direct pain stimuli. After this, the motor response, if you ask him to lift his hand and ask some question, if there is some cervical injury, you can ask him to show his tongue. In case of cervical injuries, the patient is quadriplegic, he will not be able to lift his hand, or there are patients with polytrauma which have got injuries to extremity. Even they don't open their limbs, or they don't hold their limbs up. So you must ask them to show their tongue. After that, you give them a pan stimuli and the patient localizes for it. After localization, there is flexion, and flexion is a sign which tells us that the injury is in anterior region of the brain, yet it has not involved the posterior fossa, it is still in the diencephalon. And after that comes extension, that is the decerebrate posturing, in which the limbs they do extension, not flexion. In this scenario, we came to know that there is some herniation from diencephalon toward the posterior fossa, or there is some posterior fossa lesion that is affecting brain. And if there is no response, it is 1, it is never 0. After that, the verbal response. First of all, when we ask a question from the patient, he tells us the correct answer about our question, and it gives us the impression that patient is oriented. After that, the second category comes that patient is confused. We ask him, where are you? He tells us that I am in my office. He can speak in this scenario, but it doesn't make the sense. And after that, inappropriate words. Patient will say, मैं यहाँ वहाँ. He will tell you different words without any essence. There will be no meaning in that. After that, there are components which, like, he will make sounds, ah, ooh, like that. And if there is no response, it is 1 still. After Glasgow Coma Scale, we go to the pupil. Pupil, they are the only part which we can assess externally. Some surgeons, they do say pupil, they are also part of brain. They tell us about what is inside the brain. And patient should be hemodynamically stable. He should not be any drug effect. He should not having any poisoning or anything like that for pupillary assessment. If the pupil, they are bilaterally equally reactive to light, then the patient tells you that there is no any mass effect inside. Although it cannot be okay always, but there is no mass effect. Usually these patients are the patients who don't have any surgical lesion in their brain. After that, the anisocoric eyes, they come. One pupil that is smaller in size, and the other one that is the larger one. If you are looking a patient in darker room, the smaller pupil is the culprit, and if you are looking the pupil in a bright room, then the larger one is the culprit, because during dark the pupil, they do dilate, and in light room they constrict. And what we do, we follow torch light or mobile light, and we see the pupil by that time. And after that it comes to that pinpoint pupil. Pinpoint pupil, they are usually seen with drug poisoning or brain stem lesions as well, but it is upper brain stem, that is around the pontine region. Then comes that bilaterally dilated fixed pupil. They have the worst prognosis, and once it is seen in a patient, the patient rarely revives, and it is a sign of medullary involvement. Now we come to imaging modalities. The most reliable imaging modality in emergency is CT scan brain plane. But X-rays we can also use in some scenarios, not in all scenarios. MRI and angiography we do as well, but not in routine scenarios. On X-ray skull, we can see the sphenoid sinus. Look for air fluid level. If there is some air fluid level, that is a sign of skull base fracture, and it tells us that there is some blood in the sinus that gives us air fluid level. After that, there is pneumoencephalocele. There is some air inside the brain. We can appreciate air inside the skull domain in an X-ray, and it roughly can tell us as well that there is some midline shift. And there are double densities and linear fracture. They are very hard to see on X-ray, in a good quality X-ray as well. The PA view, we again look for frontal sinuses in PA view. It shows us the air fluid level. And the pineal shift, again in a good quality digital X-ray, we can only appreciate pineal shift in a few patients. Then comes the CT scan brain plan. It excels almost all other investigations during a trauma scenario. It is the most important investigation. It clearly depicts the extent of injury, how much is the injury and what surgical need currently is required. You can decide it on CT scan. Usually a plain CT scan with bone window is sufficient. Many times the first CT scan is done quite earlier. When patient arrives us, we just do examine the patient, and the next thing is CT brain plan, and we usually need a second scan as well after 12 hours, 24 hours. It depends on the patient. If the patient is stable, you can defer it. It also depends on the consultant's wish. Then comes the MRI scan. MRI scan is not usually used in acute settings of trauma because of longer duration of scanning and doesn't add any valuable information over CT scan. Because the patient we receive in emergency, they usually have got GCS 8, 10, and they are very hard to manage in a MRI scan. And most MRI scan and ventilator, they are not compatible with each other, and we need to put a ETT and do ambu bag during all that period. The MRI scan is going on in an open MRI. In a closed MRI, that is 1.5 Tesla or above, it is not possible. Again, it is helpful in cases just like acute infarct. We go for a diffusion weighted MRI in which we can pick an early infarct, intratumoral bleeds, and bleed from any AVM. Can be done in a spine trauma when patient is optimized if other investigations are inconclusive. The other investigation is CT angio or catheter angiogram. They both are different. CT angiogram is a scan which we do in a CT scan machine, and the catheter angiogram machine scan is scan which we do in cath lab. Catheter angiography can be diagnostic as well as therapeutic. Not routinely done in acute settings, helpful in cases of aneurysmal bleed, AVM, and in infarct which present during the window period, who can be potential candidates for intravascular procedures. We can do embolectomy as well with catheter angiography. This is topogram. We usually don't use this topogram nowadays. We only see this picture on top of CT scan for scout, and yet the topograms have been obsoleted. This is CT brain plan showing extradural hematoma with midline shift and effacement of all sulci and gyri. Here we can see another CT scan brain plan with extradural hematoma. Extradural hematoma is currently, what we can appreciate easily, is thicker, and it is confined to that margins of suture. It is bounded by suture, and it will not cross the suture lines. It cannot cross because the dura is attached to suture lines, and it is not easily separable from that site. This is also an extradural showing midline shift and effacement of ipsilateral lateral ventricle. Here we can again appreciate another extradural hematoma with some air inside the skull and subgaleal space. Here this is a subdural hematoma. Subdural hematoma, they are usually thin and they are with massive brain edema. There is massive brain injury, primary brain injury apart from the subdural hematoma, and though the hematoma volume is not that much as extradural, but the midline shift is usually more. And subdural hematomas, they are more frequent than the extradural hematomas, but extradural hematoma, they fall in surgical category most often. They are most commonly operated neurosurgical emergencies. Again, this is also a subdural hematoma. Subdural hematoma, again they are of two types. The previous one, you can see this one was very thin with a huge midline shift and showing primary brain injuries. It usually accompanies with brain laceration and other type of injuries as well. This one is after the bridging vein tear, and it doesn't carry any primary brain injury, and usually they do present us in 2 weeks or 3 weeks with a midline shift and chronic subdural hematoma. They go chronic. Again, this is a subdural hematoma, and this is intracerebral bleed of basal ganglia. Again, we can see that there is no primary brain injury other than the bleed. The bleed is the primary brain injury in basal ganglia region, and usually they do present with the trauma as well as some vascular event. Again, this is countercoup injury of frontal lobe showing contusion in bilateral frontal regions. Again, we can see here this is another brain contusion showing brain injury in right parietal region. Thank you.